a lot of people aren't happy with this set of options. Similarly with brain death, right? Many want a third option, right? And basically, they want to elect to treat the dead as if they were alive. And so I'm going to unpack that this morning in 6 parts. Okay, so this is just the roadmap, right? First, just to lay it on the table, what is brain death? Second, what are clinician duties at brain death? Third, talk about the growing resistance among families to the brain death diagnosis. Fourth, the reasons for that resistance. Why do families resist the diagnosis of brain death? Fifth, some strategies on responding to those objections. And then finally, since I am a lawyer, what I want to talk about are 3 new legal attacks on brain death. All right. First part, brain death. So we start back in 1968. So back in 1968 is really when the concept was really crisply and coherently framed by a Harvard Medical School committee in this brief JAMA article. Okay, and they recommended it. And one of the things that they said was no statutory change in the law should be necessary. Like, we think we can just start doing this. We don't really need to change state laws to formally recognize brain death. That was wrong. And basically the reason is because clinicians then, and even more today, are very risk averse, legally risk averse, right? They wanted clarity and certainty about when somebody is or is not dead. So the state started enacting brain death statutes, and it started in 1970 next door in Kansas. So Kansas was first state to formally enact a brain death statute. And during the rest of the 1970s, however, as other states started to adopt brain death statutes, they weren't the same statutes. So now we have 3, 4, or 5 different ways in which brain death is defined in different states' laws. And that variability is not good, right? If there's one thing that we want to have uniformity about, it's death, right? So you don't want it to be the case that if you cross the river, if you cross the state line, that your status as alive or dead would change just because you crossed from Missouri to Kansas. So in 1981, the President's Commission on Bioethics prepared a report recommending a particular model definition that they would hope that everybody would enact. And that model then became what's now known as the Uniform Determination of Death Act. And that says, and we'll come back to this several times, that says that you're dead if you've sustained either, it's either or, if you've sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain. Okay, so that's the Uniform Determination of Death Act, a disjunctive way to qualify as dead. So fast forward up till today. Today, the Uniform Determination of Death Act has, in substance, been adopted in all 56 U.S. jurisdictions, with a narrow exception for New Jersey, which we'll come back to. Right? So this has basically been something that's legally settled since the 1980s. And it remains settled, at least legally, right now. And in fact, it's even been described as something that is endorsed by a durable worldwide consensus. Okay, so the idea here is this is settled, right? This is not one of those new bioethics issues. This is settled, and we thought we were done with it. Now, in 2008, the President's Council on Bioethics did issue a report, And in that report, at length, they acknowledged that there are some conceptual problems with the definition of brain death. Nevertheless, on balance, they still concluded that, and what they called total brain failure, which is their short term for complete cessation of all functions of the entire brain, they still concluded that total brain failure is death. Okay, there are some conceptual problems, but they're not that bad. We should stick with what we have. So it's a bright line rule. It's pretty clear. Total brain failure is death. Okay. So that's where we are. What are clinician duties when you have somebody who has been diagnosed as brain dead? First, consent is not required to stop physiological support. You don't need to ask, the patient has been diagnosed as dead, may we stop mechanical ventilation? This is in all of the major ethics codes of every major professional medical association, right? After a patient, this is the American College of Physicians, after a patient has been declared brain dead, medical support should be discontinued, right? And everyone says the same thing. Once death has been pronounced, all medical intervention should be withdrawn, on and on and on through all the professional medical associations. And the reason is because once diagnosed, once declared dead, they're not a patient anymore. Patient is something that's limited to living persons. And if they're not a patient, then there's no duty to treat. The treatment relationship has ended. So the treatment duties are turned off. So this also a bright line rule, okay? Total brain failure is death, and no duty to treat once the patient has been diagnosed and determined to be dead. But, that's the easy part. But surrogate resistance is growing. More families are disputing, and I keep using the term brain death. The better term would be determination of death on neurological criteria, but that's more cumbersome. So for the fluidity of the talk, I'm going to use brain death. But more families are disputing brain death. So just a couple examples. The Cleveland Clinic published a report where they had 13 ethics consults because family members asked clinical caregivers to deviate from standard procedures following brain death. And of course, the standard procedures following brain death are to disconnect mechanical ventilation and remove the patient from the ICU. San Francisco General Hospital also published a report in recent months. The families of patients determined to be dead by neurological criteria have rejected this diagnosis. In a report just from a couple weeks ago, this is a Toronto area provider. They said they had 56 brain death cases in the last 2 years and conflicts in 10% of the times that a patient had been diagnosed as brain dead. And then just finally, in the August 2016 issue of Neurology, this is a survey of 200 US neurologists, 50% of them reported that they had recently encountered families requesting continued organ support after the determination of death by neurological criteria. So the prevalence is higher than it's ever been in terms of disputes about brain death. And many of these cases are going to court, right? So just a few examples, Lisa Avila from Los Angeles, Alan Sanchez. These are all cases that got extensive media coverage, not just across the country, but even across the world. Israel Stinson. And then, and this is a little bit dated now, but even locally in Kansas City, Michael Todd. So why do these families resist, right? Why are they disputing the brain death diagnosis? Well, one big reason is religion, but I just want to put that to the side and come back to that later. And I just want to focus right now on non-religious objections. And there's a few of those. So one is diagnostic confusion, okay? They just don't understand what brain death is, right? These are just quotes like, since there's a heartbeat and he's warm, therefore he's still alive. Or he's just in a coma, or with rehab, or with time, he'll get better. They think, right, it's sort of like Sleeping Beauty. They just look like they're just sleeping, and maybe if we just kiss them, or if Prince Charming kisses them, then they'll wake up. Diagnostic confusion. It's a hard diagnosis to really swallow. It's not intuitively appealing. And that's exacerbated, so the diagnostic confusion is exacerbated by linguistic confusion, okay? Even using the very term brain dead implies that they're not really dead, they're just brain dead, right? Why add this extra adjective? Brain, modifying dead. And in fact, it's often used to describe brain injury states that aren't limited to brain death. Sometimes people casually apply brain death when they're really talking about some sort of vegetative state and not strictly brain death. And you have newspaper headlines, and I could give you a million examples, but I'm only going to give you like two. But newspaper headlines like brain dead Canadian woman dies after giving birth to boy, right? If she was dead, she can't die. Right? You only die once, notwithstanding the James Bond movie titles. Even the New York Times, right? These are not just ding-dong newspapers. The New York Times, brain-dead Florida girl will be sent home on life support. It's not life support if she's dead. And when Liam Neeson's wife died, this is a report, she's brain dead and being kept alive by life support to enable the family to say their goodbyes, right? If she's brain dead, she's not being kept alive. This goes on and on, okay? So this media coverage and the way the media portrays this is just exacerbating the confusion about what brain death really is. So it's no surprise that these families are confused by what the diagnosis really means. So diagnostic confusion, linguistic confusion. There's a big belief in miracles in our country. This is just one survey, right? If doctors treating your family said futility had been reached, would you believe that divine intervention by God could save your family? Nearly 60% of respondents said yes. 60%. Right? Of course, we have stories like Lazarus, but this is fueled, right? This belief in miracles is fueled. We have, like Ted Williams, had his family had his head frozen, right, and then later to be thawed out, maybe when there's a cure. And people use this service, this Alcor service. This little girl recently, her family sent her to be frozen. So we have this idea that there's a way we can avoid death. And now we're getting ready next year to have the first head transplant. So these reports of studies like this or stories like this sort of fuel people's belief that maybe death is optional. They believe, like King Canute, they can hold back the waves. Prognostic mistrust, another big fuel for these conflicts, right? The idea here is that the clinicians were wrong before, maybe you're wrong now, right? And a lot of these brain death cases follow this pattern. And what I mean is, so take the case of Jahai McMath, right? The reason she died was because after tonsillectomy, she started bleeding from the site where the tissue had been removed, lost her airway. And they filed a medical malpractice lawsuit, so they're claiming this was due to negligent medical error, right? So the idea is, well, you're the ones that killed her, or the ones that almost killed her, so you screwed up there, so how do we know you aren't screwing up now with respect to the brain death diagnosis? Similarly, Lisa Avila died because of a missed diagnosis. She died of an ectoptic pregnancy in the fallopian tubes. Again, you missed that. You were wrong about that diagnosis. Maybe you're wrong about this diagnosis also. Again, another medical malpractice lawsuit, right? If you're wrong before, I think you're probably wrong now, too. Now, in those cases, ultimately, in the Jahai McMath case and the Lisa Avila case, clinicians ultimately were correct. They really were dead. But many other times, the clinicians were actually wrong. And so we know medical error is a big problem, right? We have the Institute of Medicine report from 1999, 100,000 deaths a year caused by preventable medical error. And then we have the more recent reports measuring medical error in the United States from DHHS, from the Journal of Patient Safety, and most recently from the BMJ, right? And we know that you put these all together, medical error is the third leading cause of death in the United States. So it's not an insignificant prevalence here. And so just to focus on medical error with respect to brain death specifically, right? We have cases like Jack Dunlap in Arizona, who was diagnosed as dead and now is a college student. Cases in Syracuse, New York. Cases in LA, right? These are on the front cover of the LA Times, you know, close call in death ruling, right? These are times where these were errors, right? They were diagnosed as dead and they ultimately were not actually dead. In San Francisco, there was a New York case where the hospital went to court to try to get permission to withdraw life support because the family was objecting to the removal of organ support. Interestingly, the hospital ultimately dismissed the case because they realized, oh, you know what, they're not dead after all. Kind of embarrassing after litigating the case for 4 weeks. And there's so many of these wrong brain death diagnosis cases that they're getting written up in survey articles like this, or even in a whole book like by Sanjay Gupta, you know, they were declared dead, it was written in their chart, and here they are sitting up talking to me. So again, the error rate is not insignificant. And because of books like this, it's widely disseminated that it's not insignificant. Fifth, now those are all just negligent errors, right? Somebody just maybe wasn't good at doing the diagnosis. They didn't have a lot of experience doing it. It was just an error. But there are more culpable errors as well, and these also pervade the public consciousness. Just a couple examples. This was a case of a transplant surgeon in San Luis Obispo, California, right? And the claim was that he had hastened the patient's death in order to procure the organs. Same theory in Pittsburgh against the hospital and the OPO. And in fact, they ultimately settled. The family got a more than a $1 million settlement from those defendants. And now there's again, same sort of case. You hasten the death in order to procure the organs. That's ongoing in Chicago. Okay, so that's confusion and there's mistrust. And that's all exacerbated by the fact that people suffer from taphophobia. So taphophobia is the fear of being buried alive. And this was really well described in Edgar Allan Poe's book from 1844, The Premature Burial. And back at this time, mid-1800s, this was a real fear, right? So there were a lot of devices that were innovated around this time, like these pinchers, right? To kind of make sure that the person was dead, so you would kind of pinch them with this. Or they had a thing where you'd blow tobacco smoke into the person's butt. I mean, these are just things, presumably if they were alive, this would wake them up. And then one where you would put a little string connected to a bell in the coffin. So if they were alive and they woke up in the coffin, they could pull this and they would ring the bell and then somebody could come and dig them up, right? And this is where we get the expression, saved by the bell. So somebody claims. So the taphophobia, people want to be sure, right? They want to be sure. It's a fair feeling. So there's this cartoon where you have a physician with a stethoscope kneeling at a gravestone with a widow standing beside him. He says, "I'm afraid there's very little I can do." And I guess what's happening because of all this mistrust and confusion is that people don't believe it when they say there's very little I can do. They think, no, I think there is something you can do. Okay, so here's what's happening now. So let me just, on these confusion and on this mistrust, I just want to give a couple strategies to avoid conflict there before we move on to the legal attacks. So on diagnostic confusion, right? A couple things to do. One is just don't use the term brain death. I mean, we're using it here in this lecture hall, but I'm talking about don't use it when you're talking to families, okay? Just say they're dead, right? But or they've been determined dead on neurological criteria, but I think just stop using the word. Second, use decision aids, right? There is enormous body of literature now, more than 130 RCTs that were meta-reviewed in 2 Cochrane studies that show that using decision aids dramatically increases patient comprehension of any diagnostic intervention, right? Whether it's a knee replacement or brain death or CPR, right? And what I mean by decision aids are evidence-based educational tools, whether it's a video, an interactive website, maybe even a good piece of a well-designed literature, an option grid, right? When you use a decision aid, comprehension and understanding increases dramatically. And there really, unfortunately, are not many decision aids for brain death. Not that there's a decision to be made, but the point is you can use it as an educational tool. I mean, the JAMA has these, the patient page in JAMA, but that's a little thin. Most of the decision aids, or might just say literature that's out there on brain death that's used to educate families about it is literature that's been designed and published by the OPOs. And I think that people are distrustful that that's the source of the information, that they're not an unbiased disseminator of knowledge on this. On the mistrust point, there's a couple things to do. One is most of the brain death diagnostic tests are relatively simple bedside tests, right? Pupil, corneal reflex, ice water in the ear, right? And therefore, there's been a couple studies that show, as with CPR, if you let the family observe CPR, they're more trusting that you've done everything possible, and they accept the result more readily. Same thing with the brain death diagnosis. If they get to be present, if they get to observe it, they are more accepting of the results. And then second, get an independent medical opinion, right? Because if you think that if the family thinks the reason they're dead is because an error has been committed, then get somebody who's not tainted, right? That's independent of this facility, right? So again, in the Lisa Avila case, right, where the clinicians at her treating facility did miss the ectopic pregnancy, we're not going to trust anything that you say anymore. But when they did get an independent Los Angeles neurologist to come in, and he said, no, I also agree that she's brain dead, then they said, okay, well then maybe she really is, and then organ support was discontinued. That all said, there are these mechanisms, some strategies we can use, but some conflicts are intractable. So let me tell you what's happening on the legal front. There's three attacks on brain death, legal attacks, new legal attacks. The first one is about accommodation after death, right? And in this attack, nobody's questioning brain death criteria, nobody's questioning the application of those criteria to this particular patient, but they do want continued organ support. Okay, and remember, normally, once a patient is determined dead, organ support is discontinued. Now, in 3 states, we have laws that require that there be accommodation for religious objections to brain death: California, Illinois, and New York. But they require a reasonably brief accommodation period, which has normally been interpreted by hospitals in those states to be 24 to 48 hours, to allow the family time to convene and say goodbye. Now, in New Jersey, they have a different rule. In New Jersey, it's an indefinite accommodation. Right? In other words, we're going to continue organ support until the patient reaches cardiopulmonary death. So it's, in fact, not really an accommodation as much as it is an exemption. Right? If you don't believe in brain death, then it can't be applied to you. Now, in a number of cases over the last few years, patients in other states that don't have accommodation laws or an exemption law like New Jersey have asked for continued organ support after brain death. So in Washington, D.C. Children's Hospital, there was an Orthodox Jewish family that wanted organ support after the baby was determined dead. In Michigan, there was a Muslim family that wanted organ support after the patient was determined dead. In Massachusetts, there was a Buddhist family that wanted organ support after the patient was determined dead. And in California, this was a Christian family that wanted organ support after the patient was determined dead. All those requests were denied, and the court said, no, you don't have, hospital, you don't have to do that. I just want to make a quick pitch here, which is to expand the duty of accommodation that we have in California, New York, and Illinois to other states, right? So we have 3 states that require reasonable accommodation, right? The normal rule is if you're dead, there's no duty to treat, right? In those 3 states, if you're determined dead, there's a temporary duty to treat. And here's my quick argument for this. One is brain death imposes on profound beliefs, right? Central beliefs, central to your autonomy about life and death. Second, it's worked, right? It's worked for decades in these 3 pretty populous states, right? I looked and looked, and I couldn't find any complaints about, resources or any other issues that people were saying this has caused some sort of bad consequences having this law. Third, brain death is rare. It's pretty uncommon. Brain death comprises less than 1% of all hospital deaths. And objections are only really coming from less than 2% of the US population, right? The only people that really have religious objections to brain death are the Japanese Shinto, Orthodox Jews, Native Americans, and Buddhists. And altogether, they comprise less than 2% of the US population. So there's a quick math thing, but if you just take, if the objections are only coming from 2%, and that only applies to 1% of deaths, then you're really only going to have a possible conflict in 2 in 10,000 deaths, or 1 in 5,000 deaths, right? 2 million people die each year. So you're really only going to possibly have 400 religious brain death conflicts in a year nationwide. And because of their population and because of demographics, most of those are already going to be in California, New York, Illinois, or New Jersey anyway, right? So the minimal net marginal burden of another state enacting this law is going to be tiny. Fourth, the accommodation is limited in type, right? You only need to continue cardiopulmonary support, right? Mechanical ventilation, you don't need to do other sorts of medical interventions for accommodation. Fifth, it's a limited duration, right? We're only talking about normally 24 hours. That's it. And not even that, right? You don't even need to do that in California or Illinois or New York if there's a distributive justice problem and we need that ICU bed for somebody else. If the ICU is full, you don't even need to give the 24 hours. And then finally, and I'll come back to this, there are some conceptual flaws with brain death, right? It's increasingly recognized not as a scientifically discovered point as much as it is a value-laden, invented point. And therefore, once it's identified and framed as a value-laden judgment, then it's not clear why that value-laden judgment should outweigh the family's value judgment. Anyway, those are reasons why I think we might consider expanding accommodation laws beyond those 4 states. Although, and you could ask me this, I'm not sure I'm ready to defend a New Jersey type rule, which would be an indefinite accommodation or a flat out exemption to brain death, just a reasonable accommodation. Okay, first attack is people wanting religious exemption and accommodation after brain death. The second attack is about consent for the apnea test, okay? This apnea test is the final confirmatory test before declaring death. Right? What we do, you remove the ventilator and you see if there's a drive to breathe. If there's no drive to breathe, they're dead. And again, remember, there's no right to treatment after death, right? Once the patient is determined dead, except in those 3 states, the patient doesn't have any right to continue treatment. So the strategy here is to prevent the patient from being declared dead in the first place, because once they're declared dead, they lose their rights. Right? So the analogy might be like this, where if you had a big bag of marijuana in your car and you were pulled over for a traffic violation and the cop says, hey, can I search your car? Right? You're going to say no, right? Because if they find the bag of marijuana, then you'll be arrested, right? So you don't give consent to something that will cause a consequence that you don't want to happen. So here too, that's sort of the logic of what's happening, right? They're refusing consent to the apnea test. Since the apnea test is built into the diagnostic criteria for brain death, if you can't do the apnea test, you can't determine the patient to be dead. And if you can't determine them to be dead, then the treatment duties don't end. So it's clever, I think. So the question is, do clinicians need consent for the apnea test? Well, one court recently said, yes, you do need consent for the apnea test. There's a case, Alan Calloway, in Billings, Montana. So Alan was a six-year-old. He drowned, or I guess according to the family, almost drowned back in July. And then he was admitted to this hospital in Billings, and they did the bedside tests and are now pretty sure that he's probably brain dead and now want to do the apnea test. But his mom says, no, you're not doing the apnea test. She objects. And it is, just to point out, right, normally the apnea test is not completely risk-free, right? For somebody with brain damage, to remove the ventilator could exacerbate that brain damage, right, if they're not dead. And normally we do require consent for any intervention that does impose non-insignificant risks. So the hospital went to court in Montana, said, you know, give us permission to conduct this apnea test over the mom's objections. And the Montana court said, no, not going to do that. Mom has sole authority to make medical decisions on his behalf, including the decision as to whether any future brain functionality examinations will be administered. And now, and that's the way, that was the ruling. He's still at the hospital today, although they are now trying to transfer him home to be with his brothers and sisters. So the answer to the question, do clinicians need consent for the apnea test? Montana said yes, and I would just note that Kansas also said yes when asked this question. There was a case, this is a little bit older now, the Calloway case was just a few weeks ago. The Brett Shively case was also a little kid, also drowned. This was in Wichita, and again, did the bedside tests, wanted to do the apnea test. Parents objected, and this time the parents went to court and got a temporary restraining order forbidding the hospital from performing what the court described as a brain viability exam. Ultimately, he was discharged home, but that's at least, just note, that's a 6-week period where this is after death, where the hospital had him, was forced by the court to keep him at the hospital, and they couldn't diagnose him as dead, pursuant to the court order. And then third, just to give a sense that this is really percolating up around here, so Montana and Kansas said, yes, you do need consent. And by the way, in this August 2016 neurology survey, 22% of neurologists agreed we need consent before performing an apnea test. I think that was a surprise. Virginia said no, you don't need consent. So there's a case of Miranda Lawson from Richmond, Virginia. She's only 2. She choked on popcorn back in May. Again, did the bedside test. We think she's probably dead. We need to do the apnea test to confirm. Parents object. Orally, and they also hand a note, they're in the hospital room, they hand a note to the clinicians. They say, we refuse any sort of brain death testing, including the apnea test in our daughter, Miranda. We don't want the ventilator removed or cut off for any amount of time. We're Christians, and it's against our religious beliefs to remove the ventilator. So the hospital doesn't perform the apnea test. They go to court, again, like in other cases, saying, tell us it's okay to perform the apnea test even without the parents' consent. This time the court said, yes, you may perform the apnea test even without the parents' consent. But the parents appealed that up to the Supreme Court of Virginia, which thereby then stayed the order, meaning they can't do the apnea test until we get the outcome from the Supreme Court of Virginia. So that was in May, by the way, so that's 7 months she's been in the hospital. And I just heard last night that she did die on cardiopulmonary criteria. So it may be that the case will be dismissed and the Supreme Court of Virginia won't decide this. But still, that's 7 months that she was in the pediatric ICU, dead. So the upshot here is, again, if somebody is dead, there's no duty to treat, right? But the strategy here, and this is being disseminated by organizations that believe in the Alliance Defense Fund and others, right, where they can negate the fact by refusing consent that the patient can't be declared dead, and therefore the no duty to treat never gets triggered. The consequence of that is, that you're going to have a lot of ICUs across the United States full of, and we can't say they're dead because we haven't been able to do the apnea test, but probably dead kids. And that's not good because pediatric ICUs are often full, which means there are other third parties who are going to be who have the capacity to benefit from ICU treatment who will be deprived of that opportunity. So there are innocent third parties harmed. Okay, third attack. And this may be the most troublesome of all three of these legal attacks on brain death. And this one is asking this question: are the medical criteria for the determination of death on neurological criteria legally sufficient? Or to ask the same question another way, the AAN, the American Academy of Neurology criteria, which are the dominant criteria for brain death, the American Academy of Neurology doesn't measure what the Uniform Determination of Death Act requires, okay? So the medical criteria don't do what the legal criteria require. So the case here is the case of Aden Hailu. So this is a case from Reno, Nevada, and she's a little older. The others were much younger children. She's 19, so she's a little older. Back in April of last year, she suffered a catastrophic anoxic brain injury during an exploratory laparotomy. A few weeks later, in May, she meets the AAN criteria for brain death. But her dad says, no, she's not dead. Doesn't believe it. So he takes this to court. He loses. Trial court in Reno says, no, the AAN criteria are met. She's dead. He doesn't take that. He takes that. Dad takes this up to the Supreme Court in Nevada. Supreme Court in Nevada, and it's about 1 year ago this week, last November, rules for the dad. And what they say is it's irrelevant that Aden meets the AAN criteria because they're not the right criteria. Right? Remember, every state basically has adopted the Uniform Determination of Death Act. And the problem is, first, that requires that brain death requires irreversible cessation of all functions of the entire brain. And the Supreme Court was concerned that the trial court didn't assess whether or not that's what the AAN is measuring, irreversible cessation of all functions of the entire brain. And in fact, went on to say, we actually strongly suspect that it's not what it's measuring. And it referred to the literature by this neurologist from UCLA who says, even people diagnosed as dead still do lots of things. They can heal, their bodies can heal wounds, fight infections, gestate a fetus, or mount a stress response, right? At the University of Minnesota, up where I work, right, they can even have sexual responsiveness, even though they're brain dead. I don't know what IRB approved that study, but somebody did it. And so the point is they still do lots of things, right? So it's not clear that there's complete cessation of all functions of the entire brain. And second, the Supreme Court of Nevada was concerned that the statute requires, and this is the same statute you can have in Missouri or Kansas, right, must be made in accordance with accepted medical standards. And again, the court is concerned that the trial court didn't consider whether the AAN criteria are accepted medical standards. There's a number of studies published by the very AAN people that lament the fact that there's enormous variability in brain death determination from hospital to hospital across the United States. Variation in the number of physicians required to do the test, the qualifications of those physicians, or how the tests are actually administered. So the upshot here is the legal standard may demand more than the medical criteria. Right? There's a divergence between what the Uniform Determination of Death Act requires and what clinicians are measuring, and that's not good. Back in 1981, when we enacted the Uniform Determination of Death Act, we determined that it wouldn't be a good idea to literally put the medical criteria into the statute because those would evolve over time. So we sort of let the medical criteria float, and maybe, to use this metaphor, they floated too far away. And so it's probably a good idea not to anchor and codify medical criteria into a statute, but the flip side of that is there's been a divergence. So we may need to amend the legal criteria, we may need to amend the medical criteria, or maybe both. And then there's a second part on this last attack, is the Jahai McMath case. This is from Oakland. So Jahai was 13, suffered loss of her airway and an anoxic brain injury that resulted in brain death, declared dead almost 3 years ago, December 2013. Right? Mom didn't accept that. Mom brought lawsuits against the hospitals back in 2013. She lost all of those lawsuits. A death certificate was issued, and Mom transferred Jahai to New Jersey. Right? If you have a religious objection to brain death, then you're not dead in New Jersey, and she's been sustained there on organ support for almost 3 years. Last year, they brought a med-mal lawsuit against the Oakland, California hospital, seeking future medical expenses, right? It's not cheap to keep her body going now. And of course, you don't need to know a lot about medical malpractice litigation to know that dead people don't have future medical expenses. So it's pretty clear when they filed this lawsuit to the hospital and the clinician, individually named physicians, that she was seeking to relitigate her status as alive. And so they moved to dismiss the lawsuit, arguing collateral estoppel, which is this idea that you get one bite at the apple, right? You brought a lawsuit back into 2013 saying you weren't really dead. You lost, and the court said you were dead. So you can't come back now and bring another lawsuit, for the same claim, right? But facts do change. That's the very nature of the lawsuit, is that maybe she was dead in 2013, but she's not dead now. And if true, the court said, well, we should give them the opportunity to prove it, okay? I don't know if they'll be able to prove it, but let's give them the chance. That went up, the medical defendants took this up to the Supreme Court of California, which said, yeah, we agree, give them a chance to prove it. So they're gonna get a chance to prove it. The upshot here is Jahai is not attacking the AAN criteria themselves, okay? They're saying she no longer meets the AAN criteria. She met them in December 2013, but she doesn't meet them now. So just contrast that with the Aden Hailu case, right? Aden is saying, right, her dad would say, well, she meets the AAN criteria, fine, but the AAN criteria aren't legally sufficient. They aren't sufficiently rigorous to do what the law requires to declare death. In Jahai's case, she's conceding that the AAN criteria are legally sufficient. They're the right criteria. There's not a legal problem with them, but as a matter of fact, she doesn't meet the criteria anymore. So it's an argument of facts, not law, with Jahai. But of course, if she is alive, we definitely have to re-examine the medical criteria for brain death, because death should be irreversible. It's part of the notion of death. And accuracy is essential. So let me just give you one final case from Kansas. This is a case called the Wicked Witch of the East. And remember, Dorothy's house lands on the Wicked Witch of the East, and we think that she's dead. But the Munchkin mayor says, well, wait a minute, we got to be sure here, right? We've got to verify it legally to see if she is morally, ethically, spiritually, physically, positively, absolutely, undeniably, and reliably dead. So they get the Munchkin coroner to come in to confirm, right? And he says, she's not only merely dead, she's really most sincerely dead. So, brain death has been described as being something that's well settled, yet still unresolved, right? And the debate for a long time has been really academic, right? We have books on this. It's been covered in the last couple of years by every major bioethics journal in the world. But it's flipping, right? It's jumping now from being a merely academic debate to now being a public policy question. And it's not just a question that we're giving it more scrutiny and more debate. It looks like we're really priming up for a fundamental reassessment of settled laws and practices. Thank you.
And I think we have time for a question or two. Who has a question? Can you yell it out?
So for the refusal of the apnea test, both those cases were pediatric cases. Does that change if it's a non-pediatric case?
No, I mean, so the question was, does the apnea consent cases were pediatric cases. So most brain death conflicts are pediatric, first of all. But the question is, I don't think it would change, right? In a pediatric case, the legally authorized decision maker is the parent. If it was an adult case, there would be another legally authorized decision maker, but the question would be the same. The question would be just framed this way. Whoever the legally authorized decision maker is, parent, healthcare agent, default surrogate, whoever it is, do we need their consent to do the apnea test on the patient? So I don't think it would change at all.
I just figured there would be more emotional appeal in pediatric cases. I don't know if the court would favor more a pediatric case more than a non.
Yeah, okay, I think in general the question's the same, but to your point, I'll give you one thing. When it's a parent, it's not just your regular healthcare decision-making rights. There's constitutional rights that parents have a constitutional right to control the upbringing of their children, and so maybe they're a more protected type of substitute decision maker than a non-parent. So maybe if we're ever going to, in other words, if we're ever going to need consent from anybody, it's going to be from a parent. So maybe, yeah, could be a tougher case.
One more quick question or comment? Carla, can you speak loudly?
It struck me for a while that the paradigm cases for right to die were all cases where the healthcare providers wanted to continue life support and the family sued to stop. And it seems to me like your brain death cases are part of a larger group of cases where families are suing to continue. Do you think that's cultural change broadly, or do you think that's because the defaults in the healthcare system have changed?
So, right, so the classic cases all during the 70s and the 80s and even into the 90s, the cases that at least got to court were the families want to stop, but the clinicians want to go. Now it's the opposite, right? So that's been well observed, right? So the biggest sort of cases now in clinical ethics by volume of ethics consults are medical futility conflicts, where it's the ICU clinicians, the critical care specialists say, we're done. There's really not, this is inappropriate. This is non-beneficial. It's even torturous or cruel. We want to stop. It's causing moral distress to the nursing staff. We really want to stop now. We think it's right to stop, but the family doesn't want to stop. And so, right, this is one type, of medical futility conflict, really. It's a dispute about whether or not perfusing this body is or is not somehow beneficial or worthwhile. And the clinicians think it's not, but some families think that it is. So yes, I think we have switched around. Although I would just say, since you brought it up, there's still an amazing amount of the original type of conflict out there. It just isn't making its way to the courts. So there's amazing amounts of over-treatment where patients are being forced, or I guess maybe since there's bad informed consent, tricked maybe into all sorts of especially oncology treatment and cardiac treatment that they never would have wanted if they really knew what the risk-burden trade-off was. So we still have an over-treatment problem It's just that the stuff that's making its way to the courts is more about the right to life as opposed to the right to die. Thank you.
Very informative, very provocative. You're the only lecturer I've ever heard who got through more than 300 slides in 45 minutes. It's almost like a video. It was wonderful. Bioethics dual degree students will have opportunity to continue the conversation. Will not be in Butterworth this time, but over in second floor of the administration building, learning lab, and join us for lunch over there. The rest of us, please thank Dr. Pope. Excellent talk.